Et nous a donc rejoint sur ce plateau pour cette
I'm joined here on stage by Dr. Boukary Ouedraogo. He's the director for Health Information Systems from the Ministry of Health in Burkina Faso. Thank you for traveling all the way from Burkina Faso. You are you're a very frequent partner to this meeting. We also have Derrick, Head of Unit Capacity Building and Collaboration from the World Health Organization, so directly from Geneva. Can you hear us loud and clear?
Yes, I can. Can you hear me loud and clearly?
Écoutez le son.
Yes, very well. The sound is clear, the picture is clear as well. I know that the rules from the World Health Organization are such that you cannot travel from Switzerland. But we also have, from Switzerland, Hani Eskandar is the Senior Coordinator Digital Services at the International Telecommunication Union. I'm sorry, which is the union for the United Nations. Mr. Eskandar, can you hear properly from Geneva this morning?
Yes, I can hear you perfectly. I hope you can hear me as well.
Very clear. So you can decide to speak either French or English. I know that you speak a very good French, also because you live in Geneva. So you can decide to speak in the language of your choice. Now, this panel discussion has to do with the impact of digital tools in case of pandemics. So with the COVID-19 crisis, we did see quite a booming in the use of those technologies. This is something new, right? Mr. Eskandar, you are at the forefront when it comes to the use of such applications, and I'm sure that you saw some extreme examples. For example, in Korea on the one hand, and Sierra Leone on the other end of a spectrum. So one country with a number of resources and one with less resources. So what were the differences in between those countries?
Alors, Hani Eskandar, est-ce que vous nous entendez?
Sorry, can you repeat the question because your last sentence was not very clear?
Oui, pardon, excusez-moi.
So you are a privileged observer of those digital solutions because this is the heart of your work. Can you cite examples of countries that have adopted such tools? When we were preparing the panel, you talked about two countries that are very much opposed, Korea on the one hand and Sierra Leone. Yet both had very good strategies with digital tools. Could you tell us more about those two countries?
Yes, thank you very much, and thank you for inviting me to be part of this panel. Indeed, actually, what was very interesting that countries really leverage digital in very different manners, but with the same objective, is how to inform the population, how to get quicker and better diagnosis, etc. What was interesting in both cases, I mentioned like Sierra Leone and Korea, which are very different in terms of their maturity of the infrastructure and connectivity, etc., that they managed to reach scale. And this is one of the things that is extremely important when we talk about any of the use of digital health, because we have seen a lot of excellent pilots and excellent experiences and very successful, but they remain at relatively low scale. So in Sierra Leone, what was extremely interesting is they leverage the basic mobile channel, which is SMS and USSD, and they used the government service that was already there before the COVID to launch this service. So it's very basic, but it's extremely useful and extremely impactful as well. So anyone with even a basic mobile phone, you don't have to have internet. You can whether write to a question to the SMS 468, you can just send a keyword like check or symptoms or tips or updates, and then immediately the system will react and send you information. And you can do the same with USSD. The good things about those simple tools is that one, they reach the population immediately. It's scalable from day one. It costs zero for the end user, but also it's very much customizable to cater to the different needs. So here, what we saw in Sierra Leone, that they have done, for example, a simple self checker and the symptom checker. They were sending tips and updates and information to combat infodemic. They were using the local languages. Then they were also catering to the local context. And more importantly, that they have leveraged an already existing infrastructure that was already there as part of the government public information system. So that was quite a successful model. And we have seen some countries have done something similar, like in Niger, for example, where they used similar system, but they sent voice messages. It's an IVR where you call and you get the message in your own local language. Which is another very important issue to make sure that everyone will get the information for free and scalable. So for me, this was a very good because it's easy to use and scalable at the same time. On the other side, on the Korea, actually they have a completely different set of usage, but as efficient as with the case in Sierra Leone. We probably all know they have leveraged a lot things related to contact tracing, for example. But also they used a lot the advanced tools in terms of telemedicine and in terms of AI-based solutions to early diagnosis of COVID through the analysis of X-rays, images, etc., which was accelerated and make early diagnosis for COVID cases. And also they have done a lot of types of applications to really break the chain of transmission. And they also had a lot of data that they can leverage through AI. Both countries have managed to to leverage what they have, but with this same lens is how to reach the whole population at once. And I think this is maybe one of the messages that we can convey today is be ready with public platforms that can reach the population and then that are easily customizable, that you can create those services very quickly in terms of pandemic, because you don't have a lot of time to build up new solutions. You need to leverage what you have already.
Yes, this is very important. You have to be ready. You need to have governmental platforms to both have bottom-up information but also top-down information. So the two examples that you cited, Korea, Sierra Leone, two countries that are very different from different points of view. So that was very interesting. Now, Dr. Boukary Ouedraogo, you are also very much involved in health information systems. Can you describe very quickly the type of data that you collect and how you harvest information from the whole country in a very quickly and efficient manner? Well, thank you very much. Again, I'm going to concur and say that it's a pleasure to be here, and I would like to thank the Pierre Fabre Foundation for organizing this conference. Now, in Burkina Faso, since 2013, we have an experience in collecting data routinely. So we have health-related data that are collected, and we draft a report based on that on a monthly basis. So those data are hosted in a data center in the country. Question: what do you do with this data? Again, in the framework of COVID crisis, but there are also other diseases. So how do you use this data very concretely? Answer: well, those collected data, the previous speaker talked about it, Dr. Eskandar. I really liked what he said about the initiatives in Niger or in Sierra Leone. But when it comes to Burkina Faso, in the last 6 years, we have epidemiological data surveillance. So this is internet-based and also mobile phone-based. We started with a pilot project, and now we have disseminated that. So on a weekly basis, we collect epidemiological data. And this is really a way which helps in informing the decision-making centrally. So this model, once you have the data that are collected, then pooled, it really helps in informing the health policies related decisions. And we also look at the information that can be useful. I'm going to give a concrete example. So on a weekly basis, for example, if we see many cases of meningitis or many cases of seasonal flu, well, we have this information and we know that we need to intensify health-related information, for example, or health-related information campaigns. So from a central point of view, it provides a snapshot of the epidemiological situation, and it helps in informing our decisions and our approaches. From the health point of view, centrally, at the central level, we do have an interface through which we follow up very closely on a number of trends in diseases. And so we have that again centralized thanks to this data harvest. We also have an interface which is accessible to the wide population and to get those information. Now, on COVID or other pandemics, do you have concrete examples of measures that you implemented, maybe a curfew that you implemented on the basis of this data? So before COVID, we implemented a number of initiatives. We created a platform through which we can collect all information from labs, from biological tests and blood works. And so, as the previous speaker said, it is important to have a central platform to help with diagnosis. And so, thanks to that biological database, if you will, we were able to again, we collected data, and we were able also to place that at the disposal of different citizens. So the citizens or the health, the beneficiaries could also get information based on this aggregated or pooled data. So each player has a dedicated app. So there's an app for the government, but there's also an app for the users. And again, we provide information, but for prevention as well. And we can also help in screening people, maybe individuals who would benefit from or would need to go to the hospital. So I'm hearing a lot of information in what you're saying. But then again, the question here for this roundtable is to talk about what happened in the past 20 years. So it seems that in your country, you started using those technical tools since 2013 or 2014, as you said. 20 years ago, we were more focused on technology, on devices and not so much on data collection. What you're talking about here is more based on data collection and helps in making the right decisions. Don't you think this is a sort of breakthrough? So it's not so much reacting to a pandemic, but rather collecting data in order to prevent, and so to have both a top-down but also a bottom-up data collection. So based on data, also being able to disseminate prevention information. Yes, answer. That is a very interesting comment. Of course, what is key is the quality of the information that we collect, the quality of data as well. When someone enters information or data, first they need to input good quality information, but also they need to have trust in the system. And if they have trust in the system, they will provide good quality information. If they don't, if they're concerned about the safety of their data, they won't be providing good quality information. So then again, also users need to be sure that data that is being collected is really used for the announced purpose. So, and they want to be sure that their data is not going to be used for any commercial or other use. Yes, this is very important. Maybe the third step of e-health evolution is again to be patient-centric, more patient-centric, because obviously we need to have those individuals, those patients, they need to be willing to provide information, but in return they want to receive information, and they want to be sure that their data is properly kept. Well, it's true that in Burkina Faso, we were rather lucky because at the highest level, and I'm talking here about our president, there was a will to create a ministry in charge of digital economy. And there was a will to provide us with the right digital infrastructure. This was also a serious way to reassure our users and to reassure the users that the data would be used in the right way. Yeah, you do have a data center in Burkina Faso, right? Yes, that's right. The data are hosted nationally in the country, and this is also a massive source of reassurance. We also have a council for health information, and there are two levels. There's a national body, the SIL, and it forbids the use of health-related data if you do not have patient's consent. And also our public health body also make sure that all health-related data provided by the patient or provided by the healthcare professionals should be hosted in Burkina Faso. So we have this double way to reassure our users and again make sure that the quality of data remains high. Derrick, Muneene, you were born in Zambia. You have a long-standing career in the subject that is of interest for us. So you were a privileged witness in the last 10 or 15 years. Do you think that those tools are really a revolution in the way that we can care for people?
Thank you so much. First of all, to thank the previous speakers that have provided the foundation upon which we build e-health or digital health systems, government ownership, and the examples that my colleague, Mr. Hani Eskandar, has given in two countries that is specified. As you rightly mentioned, I have had the rare honor and privilege to see the evolution of digital health for the past 22 years, beginning in Zambia, of course, my native country. And when I reflect back, the past 20 years or so, we've seen a tremendous progress and evolution in the area of e-health, which previously was dominated by telehealth. Specifically in my own country, at the beginning of e-health programs, we early on recognized the need for patient-centered health services via a continuity of care mechanism, putting patients first, as is our motto at the WHO. And quite early enough, we were able to take bold steps to really, put digital within the spectrum of health service provision. And what we did with the team in Zambia there was to really get bold steps around making sure that patients and patient privacies, patient data, patient continuity, including privacy, is actually taken care of, because we really cannot ensure better health outcomes without making sure that we're getting quality data that is both representative of the patient's profile and also is able to follow the patient in the patient path. This is the spirit of patient-centeredness that the previous speaker was talking about. In my own country, we built earlier on a system that was smart card driven. The team in Zambia continues to support that particular system. And back, 20 years ago, using smart card in the healthcare sector as an example of a digital or e-health tool was actually quite new because back then we were very involved around data collection. Right now, of course, we need to be focusing more on other aspects such as connecting the data, standards, enabling, and etc. And so within the particular initiative I'm talking about, one of the key lessons that we learned was the need to empower patients with their own data. And so the smart card-based solution that I'm referring to was one of the key enablers of improving patient care. What we saw there was that patients themselves understood the fact that if they carried their data on a portable device from point to point, the continuity of care would be ensured and also assured. That's a major lesson that we have to keep in mind. The patients themselves must contribute to the solutions that we're building, and they must understand what these solutions mean to them. A particular example I provided as we were speaking was the instance where a patient holding a smart card was waiting for the pharmacist to provide the drugs, an update of the drugs on the patient's smart card. The system was down. The patient was aware that if they left the health facility with their smart cards without the smart card being updated, that particular interaction will not be available at the next visit. The patient was patient enough to wait for the machine to reboot, to provide the smart card to the health provider so that the record can actually walk out of the facility with the patient. So this is really a key point in our endeavor, putting patients first, ensuring that patients are aware of what we're trying to do, and making sure that the patients themselves comply or at least contribute towards the improvement of these e-health solutions. There's many examples, of course, in the African continent that have demonstrated the fact that patients themselves are critical in this spectrum of digital solutions, because normally we forget that the e-health solutions we're producing indeed have a patient-facing mechanism. And so a number of countries have been able to show that with good patient awareness, systems themselves can have good quality data, completeness of those systems in terms of the data capture, the patient care, including the quality of the algorithms, are enforced when patients are involved in the spectrum of care. So looking back, we were really quite involved back 20 years ago on data collection. But looking forward to where we are right now, I think that patients, health providers get it, that data collection goes without saying. But we have to deal with the issue of connecting the data, making sure that the data is not siloed, making sure that we can add on advanced algorithms such as AI, machine learning, and then use that particular data for predictive analytics. All these good things that frontier technologies give us cannot be achieved if at the backbone, patients themselves are not involved in the care process. Just one more comment before I relinquish this particular space. COVID has taught us a lot of things. We are seeing more and more patient-facing e-health solutions. That has really underscored the fact that we need to ensure that the health seekers, the health beneficiaries, have the appropriate ICT e-health literacy skills. Thanks.
I'm sorry to interrupt you, Mr. Muneene, but there are many information in what you're saying, and it's very interesting. In a nutshell, as you said, you went from telehealth to more e-health. We did understand that it was key to collect good quality data. We do understand that now you are striving to using more artificial intelligence to try and customize healthcare for your users. Now, I would like to ask you two questions. First question, do you think that we are reaching a revolution, a technological revolution, or don't you think that we need a society revolution? So to move from a patient-centric solution to a situation where the patient is more proactive, has a good knowledge of technology as well. So do you think that we are about to witness a technological revolution or more a society technology revolution? And actually, I have a third question. In countries of the South, do you think that you are more advanced compared with countries in the North?
Very good point of reflection, actually. Very good points, and these are very good questions. Over the years, we definitely have seen a lot of revolutions. We're right now in the fourth industrial revolution from a technology perspective, which is now leading us to the fifth industrial revolution, and sectors such as health are not left behind. But I think it's important to realize, as you alluded to in the question, that these revolutions will always be there. But the society revolution, in terms of the transformation of the people themselves, is highly critical. It's obvious that the evolution of technology will always, take place. But what is critical is for us to ensure that the societies in which these technologies live are better able to be attuned to the evolution that is surrounding them. I'm really speaking about the need for example, ICT literacy. It is extremely critical for us to have an ICT literate population, an ICT literate health workforce, so that they can indeed effectively use these e-health solutions, and especially in the era of universal health coverage. We like to say leave no one behind, but we really must make sure we leave no one offline. And this makes it possible for us to leverage the industrial revolution much more effectively when the health sector, health workforce, together with the people themselves, are indeed literate, both from an ICT perspective and to a digital health perspective. And so that's one of the priority areas. And I want to speak specifically to the modalities in which we achieve this transformation of the society. At WHO, we have released a number of normative standards, and any piece of work that we deployed was the National e-health Toolkit that we deployed together with the International Telecommunications Union. My colleague, Mr. Hani Eskandar, is familiar with this particular topic. That toolkit includes 7 pillars. One of the pillars is workforce. And that workforce pillar should really be extended towards, equipping the health workforce with the necessary skills to engage with, a technological environment, not forgetting the people that they are interacting with. You mentioned 2 points in your question, proactiveness and reactiveness. We are in a time where, given COVID, we are being reactive, making sure that we are responding to the pandemic. And so there are a number of things that are happening. Lots of solutions are being developed. Lots of programs are being put on board. Patients themselves are now more than ever able to interact, digitally with the e-health, with the health environment. Now, that's taught us a lot of lessons in as far as making sure that we leave no one behind and that people themselves have the right skills. What we need to ensure is that we sustain this momentum of awareness, we sustain this momentum of the purpose, or shall we say how critical e-health and digital health is for the long term, not just for the near term. And I think as we look back to the state of the globe at this moment, I mean, almost every direction we look, whether it's the east, the west, the north, and the south, there is one theme. And the theme is that the new normal now is more virtual, it's more digital. The new normal is extremely virtual. We need to sustain this. Between the north and the south, there is definitely a lot of uptake of solutions right now. In the south, a lot of flexibility in terms of having a number of systems being deployed. But as the colleague from Burkina Faso was mentioning, there's normally within the south the realization that it's always critical that the many systems that come up feed into one national M&D system. That's what our colleague from Burkina Faso was emphasizing. What we see in the north is emphasis around standards, emphasis around using multiple applications as long as standards are in place to ensure interoperability. I think that the South is yet to get to that level. In the South, it is a requirement by ministries that there has to be one aggregation system. That's what Burkina Faso is talking about. Whereas in the North, where there are more matured systems, the key discussions there is around data exchange, interoperability. It's a natural evolution, and I think that the North and the South have more to learn from each other.
Merci Derrick Muneene pour cette réponse extrêmement.
Well, thank you very much for this very precise answer. Now, I have a question once again for Hani Eskandar, also in Geneva. Very quickly, Mr. Eskandar, do you share this point of view, whereby e-health tomorrow, even more than today, the main challenge will be data collection and artificial intelligence to be more proactive? Do you think that's really the avenue that we're going to explore in the future?
Yes, thank you very much again. I definitely would agree with previous speakers that while the focus was very much before on data collection and building health information systems, I think we are moving now towards how we use these types of data, how we make the better decisions based on the data. But also, I think, and it's becoming very much obvious out of COVID, is that given that we need to have a more patient-centric type of services, we believe now that the boom will also happen for telemedicine and telehealth. When telemedicine started, maybe as the first type of e-health, even it was there before there was something called e-health. Telemedicine was the start. However, at that point, maybe in the 90s, it was still very expensive. The equipments were very expensive. It was required a lot of heavy investment and a lot of expertise, etc. And then we moved to more of data collection and building information systems, etc. And I think now there will be a kind of a comeback to the telemedicine because of COVID. And because of this need to provide to the end user concrete citizen-centric and patient-centric type of services for improving access to quality care, but also for self-empowerment and self-management. However, I think there will be kind of an amalgamation of different types of technologies. Definitely AI will be part of at the heart of this, because AI will play a huge role in telemedicine and in remote consultation and remote diagnosis and all those kinds of applications. But I think we need to, there is an emerging need to look at telemedicine in a slightly different manner. And to see what are the appropriate technologies that we can use today that are also scalable quickly. And I think in some of the previous presentation today, we have seen, sort of increased use of AI chatbots on social media. And I think this is one of the areas where it will see a lot of uptake in the near future, because social media is everywhere. People use it. People know how to leverage it. if you marry the AI with it in terms of natural language processing, etc., and you create chatbots that can deliver remote consultation, because currently the chatbots are mainly used for getting access to tips and information, etc. It has been used on light manner on some sort of interacting with the medical professionals. I think in the future we're gonna see much more of that, and also better uptake in different local languages, because if you would like to use those chatbots, you need to make sure that they are working well with local languages as well.
Hani
So
Eskandar,
I think
Hani
those
Eskandar,
are
s'il vous
the
plaît.
kind of the new potential and new opportunities, is how with use affordable technologies that are already used in the hands of everyone, and really be able to leverage them for healthcare. And what is interesting, I think you mentioned this, are we looking at technology revolution or a social revolution? I think it's both. What is interesting now that the push is not coming from the supply side, from the providers of those solutions, because people are now asking for those types of services, because they are so much used now to use those types of tools, and they are now willing and open and even asking to use more and more of those types of technology.
Agnès Eskandar,
Sorry, I'm
pardon, je vous
interrupted
coupe Agnès
you.
Eskandar, mais ce
Hani,
que vous dites,
sorry.
If we are
je sais pas s'il
to
m'entend.
He
leverage,
cannot hear you.
those.
On va lui envoyer un petit message pour être
So
sûr qu'il nous entende.
we will have with I think what Hani Eskandar has done and has said is really essential, because that's also what COVID revealed. Now, if you take a step back on e-health, what do we notice is that for 5 years, 10 years, or even 20 years, the players of health were creating their own tools, their own application. They were, I would say, in their own little e-health planet. And we also saw that these tools were extremely powerful, having a broader reach, recognition, AI, language recognition, and what is it? It's GAFA, Facebook, and Google. And what Hani Eskandar has said is, how do you, encourage these players? Can we invite them around table? Can we develop hand in hand with them, knowing that every day they have a reach of a million and millions of people on the planet? And what is your feeling, Dr. Ouedraogo? Thank you. I listened attentively what Mr. Eskandar said, and it's very true. It's important. And I think that it leads us to further thought. Today, we collect so much data, and we have to have a useful data. And for it to be useful, there's a lot of things to be done. We need to maybe have an architect coordinating all that. And so these skills for the countries, developing countries, for the time being, we don't have them. Yes, in Burkina, you built your own data center that is really independent from these big names to have a more trust regarding the population. On the other hand, today, the best researchers in AI are working for GAFA. How you, a country in Burkina, are you going to end up working with them, finding solutions? Well, today we're already working on the subject with Professor, because we have produced quite a lot of information and the contribution. We have a model with AI. And this is the first example that we have. Now, in addition to that, imagine the example of COVID. We have set up a system of tracking everyone who will consult. Do you have symptoms of COVID? So we have a tracking. Every day we can get text messages that comes from 90% of sanitary. So all this has been set up on the tablets. Secure data. So we've not used these data for the time being, but they're important data. And over 25,000 data in just 4 months. So these are personal data, and we need to get the machine talking. And some can do it, to really have packages. And in Burkina, we've not yet used this machine learning and also data processing. The question that has been posed with platforms, because in addition to the data that we are using and also our citizens, that they use this in social data, and you need to have what we call a merging of the data. So yes, today we have new data in terms of health, and the question of collaborating with big players, Facebook, GAFA, how these can be done, how do you integrate this in our health system, if we wish to integrate this? So I guess that everything has been said during the roundtable will trigger a lot of questions. A lot of questions are being asked. Now, let's just have a quick presentation from another country. We are going to India now. We are going to have Wana Sharma, who has been rewarded for her Kushi Baby project. It is a little necklace that you give to the babies. There's concert. You can collect information, and it's a chip that you have. So we are with India. So thank you. Can you tell us a little what this necklace is that you've developed in Kushi Baby? Has it changed during the COVID pandemics?
Hi, Lionel, can you see me?
C'est parfait.
Yes, yes, we can see you.
Okay. And can you hear me?
Oui, je vous posais la question, Mohamed Chanawaz, le projet que vous avez développé, Kushi Baby.
Kushi Baby, have you updated it because of COVID?
Yeah, so we have converted this crisis into the opportunity. As you know, it's nice to reconnect with the PFA Foundation team here. And it's an honor to be back again and talking to you. So as you know, the Kushi Baby is known for tracking the mother and baby using the digital necklace. And we have a RCH platform where we track the beneficiary right from the family planning stage to the antenatal checkup, then the postnatal checkup, and then the immunization. This is known as the continuum of care. We in the last 1 year, it has been an exciting year for us, as we have been selected as the nodal technical partner to the government of Rajasthan, that is India's largest state in terms of area. And then we all set to scale the Udaipur model, where the foundation has been supporting us to scale up across the state. And as a public health expert, we know that the baseline denominator, true baseline denominator, is the key. So we all set to conduct the India's largest digital health census in Rajasthan. And that was supposed to be started from April, and then suddenly this COVID happened, and we then use this crisis to convert into opportunity, where we come out with one application called Mission Lisa. Lisa is life-saving application, where we actually use to screen the people and then refer the people, and then it has to be tracked followed up further by the medical officer. So in the last 3 months, we have been able to track over 12 million people, as you can see on my screen. And we use this as to categorize the patient under different category. And this application that we are using to actually track the vulnerable group, as majority of the population having COVID positive are belonging to this vulnerable group. That includes the pregnant women, the elderly population, and the children. And we are using this data to actually do the early intervention and to actually arrest the further containment of this pandemic situation.
Merci Mohamed.
Thank you for your explanations. Delighted to see you again from India. We know you couldn't travel to France today, but you have been rewarded for your actions last year. And it's nice to see how all this has evolved and how it has adapted to answer also to the situation of the pandemics. Now, before closing this roundtable, do not hesitate to ask your questions around these tools. We have Eskandar online, Hani Eskandar, we have Dr. Ouedraogo next to us, and Derrick. So we have a lot of questions coming. A question. Now, when we are having a platform, what is the right scale? Is it good to have public and private sector? What is the right solution? What is the right equation? 100% public, a mix 50-50? Thank you. It's a very nice question. I think the answer, it depends on the environment, the context. Because private public, if it's private, in the case of Burkina, what happens with private data? If it's public, you need to have individual data and then maybe cluster all that, pool all this information. But in my country, we're having a kind of framework, especially at ministry level. We have had a lot of vertical actions. We're trying to now have a more horizontal approach, so that you concentrate and create a data warehouse for health data. So private, public, it really depends on the legislation and the wish of every country. Hani Eskandar and Derrick, maybe some question. First one for Hani Eskandar, Joachim, who's saying, how can we have a non-profit player with such a great number of data linked to data? Is it possible today?
Yeah, I think this was always the dilemma, is kind of who owns the data and how you manage the data. And what we have seen in many cases that when NGOs and other partners are coming and they are deploying their e-health solution, they have the data, and even the government, they don't know where is the data. Is it in country? Is it outside of the country, etc.? So that's a big thing. That's why I think this comes back to the point I was trying to make, is how to kind of be clear on what are the things that the government needs to do and what are the things that the private sector or NGOs could do. There is a trend now, is this concept of government as a platform. Government as a platform means that the government role is really to provide foundations, is really to make sure that the data is well protected and it sits with clear ownership and stewardship from the government, that some of the core services that are available, maybe through APIs and things like that, to external innovators, who will be really focusing on adding value to the end user without necessarily having to worry about all those kind of things. And the trend now is that to allow prevent data from going outside of the country before it resides into servers that maybe are in the country or outside of the country. So there are a lot of kind of regulatory and framing of the government that needs to happen. Particularly in countries like in Europe, where there is now the GDPR, where there are strict rules on how you respect privacy, etc. And this really falls into the government role. It is for the government to set all those types of frameworks and make sure to enforce the compliance with those rules, and also making sure that it facilitates innovations. The government role, I always see that their role is not to innovate. The government here is to allow others to innovate, but setting the right rules.
Merci Hani Eskandar là aussi de cette position qui est.
Thank you for your very nice answer. And it's a good idea to think about the future. Another question asked by the chat. How do you envisage a South-South collaboration in digital? Because we strongly depend on northern countries. Is a South-South cooperation possible or not?
Very good point, actually. Very good point. The question of collaboration is an area that we have been working on at WHO quite intimately, because we really cannot see cohesiveness unless we have coordination, collaboration, and actors in the ecosystem of digital health pulling together towards a common agenda. We have an African proverb that says, if you want to go quickly, go alone. If you want to go far, then go together. And so this South-to-South collaboration really sits on this ideology that sort of like predicts that when there is good coordination and collaboration and a conducive environment has been set up, we can actually achieve more together. We are working at WHO on what we're calling a network of networks. There are indeed many networks out there. And so within this framework of putting together these different platforms, we intend to ensure that all the actors that are contributing to this area of e-health are represented, and at the same time, they're learning from each other and collaborating quite effectively. We know that when we think about e-health, normally we think about the producers, but there are other actors that are playing key roles, such as the academia, for example, who are responsible towards producing some norms, standards, qualified personnel that can use the e-health solutions. We also have the private sector, as Hani was articulating, that indeed is at the front seat in terms of innovating, trying out new approaches, and etc. And then we have different actors that are, within the ecosystem of e-health that all need to be coordinated and that all need to collaborate quite effectively. So a number of networks have demonstrated how this is quite effective. EHIN is one example that has been quite useful in terms of making sure that different actors within the e-health network are contributing quite effectively. In the African continent, we have institutions such as the African Alliance and many more. So collaboration itself, especially e-health, is quite critical. If you listen to Burkina Faso, they talked about verticalization. We can achieve a uniform approach towards e-health. If we are coordinated, then verticalization would actually be minimized.
Merci Derrick Muneene pour cette
Thank you very much for your answer. It's true in the era of the digital and communities working together. Now, very briefly, a very quick answer, more a comment than a question, because we're almost at the end of this. I don't want to prolong the conversation, but I just wanted to say that this morning we spoke a lot about quantitative data. So some questions, we have quantity data, and then we add AI. We don't really explain how it comes into play, but there's this also an area of qualitative data. Now, do the methods that we use, are they going to use qualitative data? Dr. Ouedraogo, what do you have to answer? Well, it's an excellent question. I think the qualitative data that we feed, especially in the COVID case, it's mainly data. But of course, quality data is better than quantity data. And that is something that is important. And, I think that we need to push for qualitative data more than quantity, because then if we analyze, obviously we can have bias. Thank you. One last hello to the campus of Vientiane and other countries that are looking and watching us.
Voilà, viens, à nous là-haut. Je sais pas si on retrouve.
Okay, Antoine, Eric, are you still there? So what do you think of this morning with roundtables, lots of questions? Well, we're very attentive. The connection is not always good, however, but we had a lot of questions from a lot of speakers. Some questions which I believe really have interested the students, medicine. Maybe the question is, will GPs disappear in favor of machines? So they ask question, or the diagnosis tool. Maybe a GP won't exist in the future. I have a doctor right in front of me, so I can ask him the question. Do you think that machines will be replacing chatbots or GPs? Or rather, no, I don't think it's possible. It's going to be extremely difficult, a human being by a machine. I think that one of the, a machine cannot interview a patient. There are very specific questions. The machine will help the doctor, but not replace, for sure. I have no doubt about it. I don't have a crystal ball, but I can almost assure you that no doctor will be replaced. Okay, so you can reassure your students for the time being, they won't be replaced by robots. Thank you so much, Laos campus, being with us. I know it's almost nighttime where you are. So it's the end of this first part of the observatory of the e-health. So thank you all the participants for the quality and of your presentations this morning. It is 12:50 in Paris time, Europe time. So it's time for a lunch break. We will come back at 2:15 in Paris.